Well, this is I just take an index case here. This is a 78-year-old man, and his most prominent symptoms were poor urinary stream, hesitancy, sense of incomplete evacuation, has to strain to pass urine, and this has been going on for past 3 years and has been progressively worse. He also had increased urinary frequency and mild nocturia, but obviously that did not bother him much. His symptoms essentially were poor stream, hesitancy, and straining to pass urine. 78-year-old man. He's a non-diabetic, hypertensive for 10 years, but he was taking metoprolol 50 milligrams daily. Otherwise, a fairly fit man. He also gave me history that he had 2 episodes of severe burning micturition and increased frequency in the last 6 months. He probably had urinary tract infections, and he says that his symptoms of poor stream and straining are getting very, very bothersome. So that is the situation here. Now, the problem here to me was he had voiding LUTS. He hardly had any storage symptoms. Now, is he a bladder outlet obstruction? Is it Detruser underactivity? Is it a combination? But let me just put aside these questions. And I'll just tell you that physical examination was essentially within normal limits. His bladder was not palpable. DRE showed 40 grams prostate, which is clinically benign. His urine microscopy at this point was normal. Urine culture showed no growth, and his PSA was 0.8 nanograms per ml. Then, as a routine, we always do a sonography of these patients. We find his kidneys were normal. He had a post-void residue of 188 mLs, pre-void being 318, and prostate 38 grams. So really speaking, he had a normal urinary anatomy, but his symptoms essentially voiding symptoms, and we had a problem as to how best to treat him. So my first investigation, of course, was a frequency volume chart, the bladder diary. In fact, if you look at his bladder diary, I just tried to straighten it up. It's not so bad. He passes good volumes of 200, 250 mLs at a time, and he voids almost 1.5 to 2 hours every 2 hours. For his age, I thought it wasn't bad. Any comments on this? Anybody wants to make a comment on that?
He drinks a lot.
Sorry?
He drinks a lot of fluid.
Yes. His total volume was 2,425. And actually, if you look at his nocturnal volume, although he gets up at night 3 or 4 times, his total volume he passes is not bad. It's only 600 mL. So he does have a large volume, and he agreed that he does drink a lot of water all throughout. But his nocturnal volumes were not high, although he has some amount of nocturia, which he wasn't too much bothered about.
So what is the total volume?
2.5 liters or thereabouts. This is only 1 day diary though, yeah.
So according to the definitions which I said earlier, NUV 33, he doesn't fall into nocturnal polyuria.
No, he's not nocturnal polyuria. Yeah. And as a matter of fact, nocturia is not his prominent symptom. As I say, his prominent symptoms are poor urinary flow, having to strain to pass urine, hesitancy, and a sense of incomplete voiding. So
but he's not bothered about the symptoms. But if you see, he has definite nocturia. Every hour.
Yes, he does.
But it's not. It doesn't bother him. So probably we can put that.
And I don't normally do 3-day diary, and 1-day diary if it gives me sufficient information, then I did not bother about a 3-day. I was quite happy. But certainly he had bothersome voiding symptoms. There's no question about that. So I said, let's get a Euroflow, and that was his Euroflow. He's 78-year-old man. Any comments on this Euroflow, Paul?
Well, it's certainly a long voiding time, I think, depending on your time base. But he also
about 2 minutes.
The fluctuations suggest that he might be straining towards the end of voiding, but of course you're not measuring pressure, so you don't really know whether that's the case. But he could certainly have Detruser underactivity.
Absolutely, he could have, So he started off with almost 10 mLs per second, but then he slowly slowed down. Then he came back to and this probably represents his terminal dribble or something like that. But he had a fairly good volume. He had a fairly good 376 mLs. I can't remember his post-coital residual at this occasion, but he's hovering around 150 to 200 mLs every time that I did
You
that.
said earlier on that his post-void residual was 318.
No, 188. 318 was his pre-void volume at that time. Yeah, doing ultrasound.
188. Yeah, 188. Yeah.
Yeah. The 318 was his pre-void, and post-void is
So I mean,
188.
he does have a significant residual urine, which is,
Yes, he does. He does. Yeah. So that's the situation now. Well, obviously, the question to me was, what does Euroflow indicate? What were the management options at this point? Should he undergo invasive urodynamics or not at this point? I thought it would be better to treat him with something simple like tamsulosin, which I gave him for 3 weeks, and he reported to me there is no improvement in his stream or his symptoms that he had. Then obviously sometimes you feel that you might just add something else. So I put him on silodosin 8 milligrams with tadalafil 5 milligrams a day. This he had for 2 weeks, and he returned 2 weeks later saying this he was not satisfied. Now the question to me was, what do you do at this stage? Any suggestions at this stage?
Paul, please.
pardon?
Yeah. Any suggestion
can you
at
make
this
comments,
stage?
Paul?
On this stage, yeah. So he's not satisfied. He was no better with tamsulosin, and he did not improve, at least subjectively, with silodosin and tadalafil.
I think it'd be reasonable to do urodynamics then. He's 78, so certainly we would do urodynamics before considering surgery.
Okay, so I think I do have a fairly low threshold for urodynamics in such cases, and I went ahead and I advised him that we need to do urodynamics to find out what's happening to your bladder. Is the bladder a problem or the prostate a problem? Yes.
Yeah, a small question.
Malik. Yes, Malik.
A small question. We see a lot of people, when we see this uroflow, we definitely know it's a staccato flow. So the bladder is actually most probably underactive. So we are not sure about his obstructive symptoms, but we have seen a lot of people who would add a cholinergic, sort of a methanical to these kind of people. The reason why I'm asking this is we get enough prescriptions on a methanical. So my belief is we need to do urodynamics, and there is no actual treatment for any underactive bladder at this point of time. So anyone clear air on the methanical at this point?
I think Malik, I will come to that later on, but the current evidence suggests that, and even on none of the recommendations now have more or less given up methanical as a treatment of choice. Even if you demonstrate on urodynamic evaluation that he has Detruser underactivity, which is demonstrable. So I think that is the current situation now about methanical, but we can discuss it later. Let me come back to urodynamic evaluation. What I've done here is I have just taken the voiding part here. Of course, the storage symptom, I can say storage was good. He had no overactivity. Paul, you may agree that this is a acceptable quality stress. You can see all those spikes and so on. And this is his flow. I'll give you the readings here now. He voided with a period Qmax of 38 centimeters and Qmax of 9 mLs per second. But let's see what has happened here. He has got a lot of straining, particularly toward the end of maturation, yet producing a fairly poor flow at this point. He voided a sufficient volume, 409 mLs, with a PVR on the bladder scanner was 138 mLs. So that's our urodynamic evaluation. So anybody wants to make any comment on this?
So I think I would ask Paul that this period Qmax of 38 centimeter, is he happy with this? Because if you look at the end filling pressure, if you go back to the filling phase and then you see the end filling pressure, it is about same, about 38 or something, right? And the same thing continues into the voiding.
No. End filling is here. It is less than 10.
But where is the line for voiding?
Where
did you give him command?
No, wait a minute. May not be able to show you that, but this is the command. End filling phase, Miction command. Can you see the Miction command here? Miction command. So here. Can you see my arrow? This is Miction command. And he
Okay.
actually started voiding here. Yeah. Okay. So that's
Okay.
the
So-
situation. So this is the filling, and this from here we start the voiding. Yeah.
So I mean,
okay, right.
if
Paul,
you
please.
if you do the maths, he's not obstructed. His obstruction index comes out to 20.
Yeah.
Mhm.
So normal is 20 and below. Obstructed is 40 and above. So
That's
he's
right.
not obstructed, and you know he's straining a lot because I assume he gets. You see, he gets. It's quite difficult to interpret sometimes the voiding phase in patients who strain a lot. This is good quality. I can't see a cough at the end, but I assume that's okay. Shirish.
There is coughing in there. There is coughing there. Yeah.
It's behind the pictures.
I can show you
so-
those. Yeah.
Don't worry, I believe you.
Okay.
Don't worry. So I would say that he's not obstructed, and therefore I would not offer him a TURP. We would offer him intermittent catheterization if he was worried about his voiding. But I think one of the things again with
But
this,
again, Paul, he has no symptoms of that kind. I mean, his frequency is within control. That doesn't bother him.
it
So
doesn't.
if you're saying that he's a high residue responsible as a frequency, the frequency is not his prominent symptom.
Sorry, what bothers? What
What
bothers?
bothers is poor stream and straining. He
Well,
never had to strain before, but he's straining now for the last 3 years and is getting worse progressively, which is what is bothering him.
Okay, but you've no evidence that he's obstructed. So you certainly see some men who have both a degree of obstruction and a degree of Detruser underactivity.
Correct.
And I think it's reasonable to offer them a TURP.
Yeah.
I would always tell them that their outcome will not be as good as a man who has a strong bladder. But this man has no obstruction and he has a weak bladder. So his outcome on our evidence, he will not be improved by a TURP and he will not empty his bladder any better.
Okay.
Yeah, but Paul, according to your formula, the bladder contractility index comes out to be 83, which is not very bad. And there I have read your papers and other papers about this bladder contractility index, which is most important thing for the Detruser underactivity.
Yeah.
And I think in patients like him, with a good counseling, if you do TURP, some of them may be able to empty their bladder better. Because I know there are, studies showing that if the BCCI is between 50 to 100, 100 to 150, and versus the outcome after the TURP. So my take, maybe for the sake of discussion, if I say that I would like to, after a proper counseling, because his BCCI is about 83, not so bad. Below 50, I would take it, very bad. Can I offer him TURP? I mean, devil's argument.
What would be very
Shirish, can I make a point?
Yeah, what would be very interesting in a man like this is to ask him not to strain, just to use his Detruser contraction.
But Paul, there is only one reservation that I have in calculating the BCI, and that is that the amount of straining that can actually induce a high flow temporarily may actually give you an erroneous result of the DCI.
Well, I mean, I think that's a good point. It's a good point because the BCI is really, I think, comes from the assumption that all effort to void comes from the Detruser and not from straining.
For straining, correct.
And we don't know how effective straining is.
Sanjay, you want to make a point,
Yeah.
Sanjay?
So there are some things here which suggest to me that this patient might do reasonably well with the TUR. One, and these are things not captured in the definition of contractility and bladder contractility index. The first is, this is a sustained contraction. So the bladder contractility index does not capture whether the bladder contraction is a sustained or an ill-sustained contraction. You can see a good sustained contraction. In fact, for more than half or maybe 2/3 of the bladder contraction, you find that the flow is almost close to zero, but his bladder contraction is above 35, 37 centimeters of water. So the point here is, although we expect when we do the bladder contract outlet obstruction index calculation that at different points in the curve, it should not be too much different from, if you measure it at PDET Qmax, it should not be dramatically different from a different part of the curve. But you can see here towards the latter half of the void, there is a contraction which is close to 35 centimeters of water and the flow is close to zero. And it's a sustained contraction. So I would feel that this patient, there is an equivocal obstruction which is not getting captured in the first part of this curve and by the indices here. So I would be obviously have to counsel this patient because his odds are not as good as somebody who has a good contraction and obvious obstruction. But I think he has a reasonable chance.
That's right. Sanjay, I want to just take you ahead in some sort of a discussion on this. So can I move ahead?
Yeah, sure.
Slide, yeah. Okay. Right. So I just want to put a thought rather than Anish asked me to put the guidelines, and I have a set of guidelines, but I would like to spend about 4 or 5 minutes in some thought process with the question of Detruser underactivity as a whole, if you allow me. And what I want to say here is that Detruser underactivity has complicated the understanding of diagnosis as well as management of bladder outlet obstruction in the recent past, because both BO and DU have similar clinical picture. I want to just bring you this slide here. I hope it moves. Yeah. What I want to say here is that Detruser contractility is something which changes with time in life, and as the age advances, the contractility goes on falling, both in force of contraction, the velocity, as well as sustenance. And at the same time, as the age advances, you also get a gentle rise in the outlet resistance as a result of hyperplasia of prostate, as a result of maybe adrenergic activity or loss of compliance with the prostatic tissue. So what happens basically, you have on one hand a weaker detruser, other hand you have got a stiffer and stiffer outlet, and that produces a very complex voiding dynamics at that particular point. In the end, what happens is that the terms Detruser underactivity or bladder outlet obstruction become relative at that particular point. And this is the point I wish to drive a little further and just say that. So this is what is happening in life, and this is what keeps happening as the age advances. So the whole entire dynamics of bladder outlet changes, and therefore the term outlet obstruction may not be absolute, but may be relative. And so is the term Detruser underactivity is a relative term relative to the outlet mechanism rather than the absolute obstruction, as we call it by pressure flow studies. So Detruser function and its response to outlet is what is bothering us at the moment. And I just want to go back to some of the evidence in literature that Chris Chappell has shown that Detruser underactivity is present in 48% of men with LUTS over their 60 years. He's been saying all along, and I think is one of his papers in 2015, they said. Professor Abrams, now I wish to quote you that you have been consistently saying that Detruser underactivity in a chronic retention is an underactive Detruser right from inception and is unrelated to the bladder outlet obstruction. Am I right to quote you?
No, I think that's a misquote. It's what they say when the politicians always say,
that's why I want to put it across.
I have been quoted out of context.
Okay, right. So no, but when we discuss chronic retentions, please clarify yourself. Yeah.
What I would say is that you can't assume that every patient with Detruser underactivity has obstruction, because lots of them don't.
Absolutely.
So if we look at the cases we've identified in our urodynamic database, then many of them have no obstruction at all and have presumably never had any obstruction, because we don't think obstruction goes away.
But would you agree that Detruser underactivity could be a part of aging? Is that?
Well, in fact, again, if you go back to Alan Thomas's papers, which, remember, had a follow-up of a minimum of 10 years, an average of 13 years. In untreated Detruser underactivity, there was no change in contractility index over 13 years. And these were men who were in the age group 55 to 75.
Mhm.
So if what you said was true, then we would have seen a reduction in contractility. Now, I think, you see, the problem is our papers are the only ones that give natural history. There's almost no other information because, of course, in order to prove your hypothesis or disprove your hypothesis, you would have to be doing pressure flow studies on a large group of people, say at least every 10 years of their lives as they get older. But of course, that information is not available. So we don't really know. But in men, it seems to be less of a problem than in women, because if you take 100 women with low flow, then of course the vast majority of them have Detruser underactivity as the cause. So it does seem as if women have an increasing prevalence of Detruser underactivity as they get older, but we don't have that evidence of men.
But again, the pressure flow study is also an indirect way of measuring Detruser contractility, isn't that right? I mean, you are not measuring neurophysiological strength of the bladder in terms of actual strength of the muscle, the velocity of muscle shortening, and the actual contraction strength, are we?
So, Shirish,
Because we go by Detruser pressure, which depends on the outlet as well as the strength of Detruser muscle.
Of course, yeah.
So that's why all our studies of Detruser contraction or our interpretation is indirect in the sense that we do not measure the Detruser contractility as a neurophysiological measurement. It's an indirect way of measuring, which also depends on bladder volume. It also depends on the outlet resistance at that particular time.
Right. So, Shirish, in the interest of time, can we? Would you like to sum it up and
Yes. I'll come to that. Yeah. So,
please,
majority of Indian urologists believe that Detruser, my colleagues, Detruser underactivity, serum chronic retention, is secondary to long-standing bladder outlet obstruction and is partly reversible after relief obstruction. And I think this has been my experience also, that we have seen patients who have after relief obstruction have shown a significant improvement in Detruser contractility, at least half of them. If it is an acontractile Detruser, then obviously it is not, usually it's a bad news. We don't see anything in improvement in that. Yeah. But animal experiments have shown that in rabbits, which I came across very recently, that this Detruser underactivity can be induced by urinary obstruction by tying those knots around the bladder necks in the rabbits, and is reversible after relief obstruction. Unfortunately, we don't have any human models as available. As Paul has said, if we continue doing it in a community like that for a large and longer time, we may be able to see. But we don't have models to verify these findings. So I think the philosophy of management really, because bladder outlet obstruction is not a life-threatening condition, the philosophy of management is improve the quality of life and prevent serious complications such as stones, diverticular infections, and so on. But the fact is that we need to answer. The question we need to answer are the phenomenon of impaired Detruser contractility in the long-standing case of bladder outlet obstruction. The relationship is not yet clear. Also, some of those patients develop lower Detruser compliance leading to upper tract damage. That mechanism is not clear. The decision of surgical therapy in patients shown to have DU, we do not know whether we are doing the right thing or no, because we cannot interpret the results or have outcome measures, and we don't know what is the fate of underactive Detruser after effective relief of obstructions. That is, the other questions we need to answer. So I think to sum it up, the real understanding of pathology PPH in bladder is about answering one single question: is how does this Detruser handle the outlet, the altered hydrodynamic resistance of the outlet? And therefore, I would say that in conclusion, the Detruser function now plays an important role in predicting the results of treatment in counseling of the patient. And therefore, I come back to the philosophy which Paul had presented at the end of his talk, is that urodynamic investigation is probably mandatory in all patients prior to invasive treatment, except for the for the patients who present with overt complications. So that is what I say, because of then we can have a better idea about the outcome, and we could be able to counsel the patients much better. That's what I
So
say.
thank you, Sri